So the topic that I got was building patient trust. So thinking from a social work perspective throughout this. Uh, hope everything I say kind of makes sense from that. So next slide, please. So some of the things that we'll think about in this is some of the approaches that I take out here at our clinics, using a trauma-informed approach, thinking compassion versus confrontation, and then a couple of suggestions to building rapport that I found from an article in reading this. Next slide, please. Or actually, next two slides, if you wouldn't mind. So first thing's trauma-informed approach. So kind of thinking back, looking beyond the relapse, and how I find this to be helpful is not getting stuck when they're talking about a relapse or a slip, especially in the higher level of care groups that I'm the therapist for. So we look beyond the relapse and kind of explore the reason for what could potentially be an avoidant behavior. Lisa Ference, who is a therapist out in the Baltimore area, she had this saying, as long as it's healthy and it doesn't work, we didn't fail. We just found a way that wasn't effective. And that's a mentality I try and take to as many of the groups as I can, and trying to learn some new behaviors with that. So I then tend to look at groups as in groups, I'd look at it as relapses as a self-destructive behavior, where they are using the substance to avoid feelings that they have in that moment. So we talked about the cycle of self-harm, where they have the triggering event, then they experience the negative experiences such as negative cognitions or negative affect. Following that, they experience tension and anxiety, which can include things like dissociation or analgesia. Then the outcomes, we look at both positive and negative. When I say positive outcomes, when we're talking about relapses and slips, a lot of the group members' eyes get rather large. And we think about it from the fact that the relapse did help them in that very brief moment, but then very quickly the negative outcomes tend to fall in, typically including realization that their days are starting over, could have led to legal issues, complications with CPS cases, or different things like that. So following that it triggers their emotional vulnerability that leads back to their triggering events. So it sounds kind of harsh at times, but then we talk about it from the reacts model, where we try and get into the whys that they might have relapsed. So we look at relationship dynamics, their emotional awareness, awareness of their five senses, the context that they're in, looking more than from a person and environment perspective. What were their thoughts? And then what were the sensations in their body to bring in the physiological responses? So for me, whenever I actually did this group last week through the biweekly clinic, all the way down to the ICOTE, and the response was actually pretty straight across the board, as far as a lot of them still needing to focus on their emotional awareness, and also their thoughts, which then helps them feel as if they're a part of the treatment team and identifying goals for future group therapy sessions. So then, thinking about it from a psychoeducation standpoint, is it begins to normalize their experience. So we think about stages of recovery, pre-contemplation, contemplation, preparation, action, and maintenance. So it normalizes the experience that they have felt and are most likely still feeling in early recovery. We want to be upfront and honest with them, like we ask them to be with us. Looking at the whole person provides us with the opportunity to remember they have underlying reasons to their struggles. They're not just a person who's struggling with addiction. And we'll also talk in a little bit, there are also a person who may be struggling with other comorbidities. And then by taking a person and environment approach, we assess what they have the capability to change, what they cannot change, and then encourage them to continue striving for their own individualized goals. Today, I actually asked the groups, when we think about kind of building that patient trust, what to them is the most important things. And so there are about 20 people in the groups today. The top three responses were honesty, non-judgmental tone, and being empathetic with them. For up here, they felt like we do a pretty good job of that. Some of them had mentioned a couple areas that they would like us to grow. Some of the other responses that they had were respect integrity, eye contact or other forms of nonverbal communication, strong boundaries, and then maintaining confidentiality. They want to be able to feel what they share in group is going to stay in group, but they also know that that's within reason because of the treatment team format of this. Next 2 slides, please. So thinking of compassion versus confrontation. So with confrontation, there is a time and a place to confront the client, but it's important to remember where they are. So we think about kind of the way the treatment teams are set up. We have the physician, the therapist, and the case manager. The way that we kind of view it out here is our case manager is kind of the keeper of the agreement. They help keep the therapist and the physician, in my opinion, in check to make sure that we're being fair to all the clients. But they're also the ones that kind of, reinforce the policies and procedures. So it doesn't then impact the therapeutic alliance. We actually had an interesting situation out here where one of our clients got a little upset that they were being dismissed because it did come from the case manager. They wanted it to come from the therapist instead. Confrontation can have the client lead to feeling attacked and damage the therapeutic relationship. When we get more into kind of those 10 suggestions, if we're using more closed-ended questions, then it gets into them feeling almost as if they're being more interrogated, which then can negatively impact the therapeutic relationship. Next slide, please. So then with compassion, we want them to feel as if they're being valued. We want them to feel that we have understanding of their circumstances or being empathetic with them. So if we kind of think about compassion during the COVID-19 pandemic with changes in clinic policy and procedure, I feel like we were very compassionate with a lot of the changes that we'd asked of the clients, but we also asked of each other as the providers or the therapists or case managers. We had to adapt very quickly to an ever-changing situation. So out of curiosity, how have your clinics offered compassion during this time? I'm a therapist. I'm very good at waiting people out.
One way we offered compassion is we gave them the option of whether or not they wanted to come into the office or do telephone, or we even had Doxy.me and Zoom going, and a lot of the clients like the option to choose.
Other ways.
At New River, we talk to them about each week about what they're experiencing related to the virus, and we did that from pretty early on and offered education around the virus for questions that they might have had.
Okay.
One of the things we had to do was change a lot of pharmacies and kind of negotiate with pharmacies to provide medications for some of our patients. Everyone had to go like 2.5 hours away, and there was a lot of resistance. So we had to do a lot of letter sending, and just for them to get their meds. We didn't hold them to that one pharmacy rule.
Okay. How are you hoping to maintain some of these kind of compassionate thoughts throughout the transition back to in-person visits?
Well, for our patients who are having trouble with transportation in general, we're going to keep one of the groups as an optional Zoom group, as long as we're able to get to negotiate with labs in their areas in order to get the correct urine drug screens. So for those who had problems being compliant before because of transportation, that would eliminate that.
Nice. Other ways you're hoping to kind of maintain this level of compassion?
For us at Camden, I think we've seen a lot of people's mental health decline, as well as increase in relapses of some people. I think being mindful that the ongoing effects of their mental health and keeping a close eye on that. whether it be referring to a psychiatrist or maybe increased therapy visits or whatnot, maybe more groups, whatever, just making sure that they have that extra support that they need.
Okay. I know one thing that I carried out through all the groups is each week it was checking in daily with the anxiety, the depression, kind of monitoring where they're at given the COVID pandemic, and then kind of asking them to monitor that as well. Any other thoughts before we move on to the last objective? Okay, next 2 slides, please. So we think about kind of some ways to build rapport, speaking directly, simply, and honestly. So being mindful of word choice, and that's including jargon, not speaking down to them. The idea is to speak adult to adult rather than authority to subordinate. I know that's something that a lot of us really try to do, but it can be amazing when we're getting into the idea of perception and how our word choices or our postures can be perceived differently than what we're intending them to be. Asking about their thoughts and feelings about being in therapy. And so instead of assuming their readiness for change, asking them directly about their experiencing and entering treatment. So thinking about it from like a strengths-based approach and empowering the client by sharing the amount of strength it takes to enter the treatment facility. That's something that I tend to reiterate throughout their treatment, especially if they're struggling with relapses, is how difficult it is to walk through our front doors. And to be open and willing to talk about their experiences and their struggles every week. Focusing on the patient's distress. It's important to remember they're not just a person who is in recovery. They're a person who may also be struggling with depression, anxiety, mood disorders, thought disorders, traumas, or other medical complications. So by using the whole person approach, they'll hopefully feel as if we're being empathetic to the entire individual, not just focusing on their addictive part. And I use parts language a lot through an internal family systems approach, and kind of thinking that, when they're first addicted or when they're addicted to the substances, that a lot of their life is based around addiction. So the choices that they make day in and day out, as they start getting into the preparation phase, hopefully that addictive part begins moving further away from the self and starts the transformation into a recovery part. When the recovery part's fully transformed, hopefully then it moves closer to the self again, and they're able to make a lot of healthy decisions based around their recovery and what's best for that. So offering encouragement there as they're learning to maneuver their distress. Acknowledging the patient's ambivalence. So kind of thinking about it maybe from a grief approach and discussing how clients experience the grief cycle through recovery. They kind of mourn the substance that was there for them a lot. So it does a couple of things, includes how difficult it is to not use substances. By acknowledging the ambivalence, we communicate an empathetic response and open the dialogue that may have been concealed in the past. And then exploring the purpose and goals of treatment. So working collaboratively with the client in developing treatment goals. It helps empower the individual using psychoeducation, laying out the policy and procedure of clinic, and then allowing the clients to be open about topics that are important to them will give the clients a sense of empowerment in their own treatment. Next slide, please. So then discussing the issues of confidentiality. It's an area that, at least up here in Morgantown, we review pretty frequently in sessions, especially with the requirements of self-help meetings. With some folks choosing not to disclose that they are taking a medication-assisted treatment, where others are more open with it, so not divulging that. But also it allows them to know how serious we are as a clinic, how we take issues pertaining to confidentiality beyond the therapy room. And then, we tend to see as therapists a lot of our group members in individual sessions too, as long as our schedules allow. So it's letting them know that confidentiality expands from not just the group room, but also to the individual room. And by doing that, it will hopefully allow them to open up with us about a lot of their underlying issues. That while we might let the treatment team know that we're working on specific things, we're not letting the treatment team know per se what the details are of those specific things. So if we're getting into the trauma narrative, they're not going to get, the treatment team doesn't need to know the whole narrative, but they might need to know that we're beginning trauma work and let them know maybe some signs and symptoms to look out for and offer encouragement along the way. Avoiding judgmental comments. Providers should communicate a sense of positive regard and respect for the patient. Being cautious, not using the words fail when someone's being dismissed to maybe a higher level of care, or not dismissed, word language change, transition to a higher level of care. Our clients are not just addicts, they're a person who's struggling with a highly troublesome habit. We want to appeal to the patient's areas of positive self-esteem. It's important to not get lost in the patient's turmoil, but to also assess the patient's area of strength and competence. So when we think about doing their initial assessment, thinking about what their strengths are, how they've made it through recovery stretches in the past, and encouraging them to maybe tap into some of those positive resources that are still there. Acknowledging that therapy is difficult. It takes courage and hard work to participate fully in therapy. It can challenge the previous held belief that seeking help is a sign of weakness. We can relate to therapy almost the same way as a broken bone. Although it hurts, it allows the patient to heal and to regain strength. And then wanting to ask open-ended questions, but more importantly, being a good listener following asking the open-ended questions. So add structure to the process by asking clinically relevant questions that allow the patient to expand on their own feelings. Open-ended questions prevents the individual by feeling interrogated by asking closed-ended questions. And I think we all are well-versed in asking open-ended questions. Next slide, please. So kind of in review, thinking about what a trauma-informed care approach would look like for each of our clinics, and how we might be able to implement being understanding of what could potentially be the underlying reason to relapses. Even in the school systems, I'm not a school counselor, but having read some information on the schools, figuring out why students are failing as opposed to just punishing disruptive behaviors in classes, but exploring those deeper reasons. Maintaining positive regard for our clientele. Self-reflection for growth to increase awareness of potential issues pertaining to trust. So whether we're using clinical supervision or we're using treatment team discussions, I think anytime we're able to grow as a provider, it's really important to keep that in mind. And then also maintaining honesty, being straightforward with our clients, but also within reason. One of the clients stated when I asked them about what their thoughts were, they had shared that honesty was really important to them, but they didn't need to know that their therapist was learning to quit smoking. And then when the therapist said, oh, so I can completely relate to your history of IV heroin use, it really kind of discredited then what the client was going through. So finding that appropriate balance along the way. Any questions, comments? As my group's here, concerns or rude remarks?
Thank you so much, Phil. That was excellent. So any comments, questions for Phil? Feel free to chat in as well if audio is a little spotty. Phil, I actually had a question. I'm not a clinician or anything, but I know something that has been addressed and things that I've heard are body language and how you think that may affect as well. Because I know you touched a lot upon, how you should speak and everything like that. But I was wondering if you had anything about body language as well.
Body language is important. In person, I tend to joke with the clients that if I'm sitting there with my arms crossed, slouched back in my chair, are they going to perceive that I care what they're talking about? Oftentimes the answer is no. And And so, you know, how we're sitting, our posture, our tone of voice, the way we inflect certain words, all is very important in trying to be empathetic with the client and building their trust. You know, even from how we enter the room, some folks have expressed concerns that at times people enter the room and they're like, oh, I don't like them, because of just how they walk into the room, because we're really quick to judge other people. So just, you know, I guess that's kind of my very short answer to meta communication.
Thank you.
Can I jump in here? This is Laura. Also add how the treatment team is set up. So if you have, you know, multiple providers in a room with multiple patients, being on the same level, like being in a group, preferably without a table as a barrier in between you. Even it seems like a small thing, it can feel really different to patients if you have clinicians sitting behind a table versus really just part of the group.
A lot of times we'll intermix too. So like Dr. Hirschler and Olivia will sit more towards the front of the group, but I'll go sit by maybe somebody that I perceive that might be struggling a little bit more. I could use some extra support or feel connected. Or I just plop down in the nearest open seat.
Thank you both so much. Any other comments or questions?
I guess like this, any tips from the group on how to run the Zoom groups when the communication is very shoddy? Like some people can hear, some people can't hear, and you're asking questions and someone might start to answer and then someone else jumps in because they didn't hear the answer. The times when the telecommunication is running well, it's no problem, but other times when it's not, it's a problem. I don't know how best to navigate that.
For one of the things, so for me, it kind of depends on the group size. So some of the higher level care groups have been a little bit smaller, so I've been able to keep everybody off mute. But for some of the larger groups that are, you know, upwards of 10 to 12 people, I tend to have to, I've transitioned a little bit by talking with other folks up here, but I started by just calling on people and then unmuting them one by one. That felt very lectury and teachery to me, and it felt gross. And so one of the suggestions that was thrown out is, while we keep everybody on mute, we ask a volunteer to go first, we pick somebody, and then they pick the next person. Kind of the benefit of that is that, one, we know everybody's names because they're listed, so there's no reason for us to not, unless they're on telephone. But it does allow them to kind of feel connected to each other and learn each other a little bit.
That's a really good idea. Thanks.
Thank Katie. She threw it out there for me.
We also use the chat feature. So if people are having trouble with connectedness, I ask them, like, we work with them and then we say, hey, I'm gonna ask you to just chat your response because we're having trouble hearing you. And that way they get to participate even if they're having trouble with their connectivity.
One of the clients that we had that can only use telephone for group threw out that it's important that we as the providers remember to kind of ask them directly if they have any questions, because the first time they participated in group, that didn't happen and they felt like we forgot all about them. So, you know, it's also getting feedback from those that are in the room as well, from what their side of it is.
Anyone else have any comments or questions?
I have a comment. We've had, whenever we've done our Zoom groups, an issue that we've had is just people's not as engaged or focused. Like we've had one, well, not just one, but like how they're cleaning their house while they're trying to do group, or they leave the room for a little bit and we see the ceiling up. We notice that we're looking at the ceiling. It's like, wait a minute, where'd you go? And has anyone else experienced that?
Yeah, we
Yes,
experience it all the time. And I call them out on it. So I'll say, Sarah, I notice you're no longer in the frame. You need to stop that and get in the frame right now. Or I notice that you're cleaning your cat while we're talking here. You need to stop doing that, please. And imagine we're in the same room physically, but we're not, we're in virtual. But we need to show the same respect to everybody.
Good. Well, I'm glad I'm not the only one. Okay.
Our case manager does a reminder too at the beginning of med group. You know, reminder, just a general reminder of confidentiality, limiting who's in the background, but also staying within the frame at all times unless you're going to the bathroom.
I was just going to say this too, and I see Dr. Baltierra just mentioned it. Sometimes I'll see people smoking or vaping in the frame, and I'll also call them out on that and say, you need to stop that, please.
And I think it helps. I really conceptualize it. It's like running a whole new group. So there are completely new norms around behaviors. And so sometimes in the beginning of new groups, and so I've been doing this with these Zoom groups, is just to have people go around, instead of introducing themselves, because everybody can see everybody's name, to go around the squares and say, you know, what's kind of a Zoom group rule or guideline that we try and follow. No smoking, which we didn't have to say in the old group because obviously they weren't going to be smoking. But in this group, we do actually have a say to say it because they're in a completely different environment, and that can help them, you know, acknowledge what the rules are to one another, and even help enforce those. We've had, my biggest concern is when people just disappear. So their script has been called into the pharmacy and they just drop out of group. And what do we do about that? And often it's people that we're a little bit worried about anyway. So we can do a follow-up call either after group, or the case manager or MA could do a follow-up call during group, or making sure you address that behavior the next group to say, hey, you know, Cheryl, I noticed that like halfway through group, we lost you. Tell us what happened. And then go over the rules around if you suddenly need to leave, go ahead and put it in the chat box that, hey, I have a crisis, I need to leave, or hey, I'm gonna step out of the frame right now because I have to use the bathroom, or my child just fell down. Just keeping in touch with us about what's going on. And they don't want to interrupt, is, you know, what people will say, then just put it in the chat box and let us know where you went if they just are stepping off and coming back. But this has happened to all of us, so it is absolutely, I think, probably universal.
I think something else that we do too that we've seen that's been helpful. So when we have in-person appointments, group appointments, we ask our patients to check in 30 minutes early. And that's whenever the medical assistants did all of the vitals, the drug screens, and things like that. Since they're not in person and they're done virtually through Zoom now, we still ask our patients to log on 30 minutes early. And then what we do with our medical assistants is we have them admit them into the room and consent each patient, and also go over all the rules and guidelines for group before we actually have the group.
At New River, we haven't been doing group since we've been having virtual visits. We're just having individual visits. And I've been amazed at the, similar to what everybody is saying, but also that people are connecting from being out at McDonald's or at Lowe's or at just anywhere. And so we are starting to talk to people a little bit about, this is your doctor's appointment. This is your medical appointment for, I'm a physician assistant medical provider, so it's not for the counseling session, but to say this is, you know, this is this special time that has to be dedicated. And we're calling them individually, which means they have to be available for a couple of hours while we're waiting call, but that would be the same couple of hours that we would be seeing them in group. And one of our patients actually suggested that that's a good time to do a virtual meeting. So I've been suggesting that to people, but it's just really interesting to me that people, and this is true in my, with my practice that doesn't involve MAC patients as well. People just, it's like they're calling their sister, you know, to chat from wherever they are. So to just emphasize that this is, you know, a clinical situation that's private and needs to be focused and that they need to be available has been our struggle.
Yes, we've had people driving. So that's another group guideline, which is to pull over. If you're in group, you cannot be driving with group. And it seems obvious, but you know, just helping people with the new norms of Zoom groups, I think is all around important, and will make our job easier and will make them better able to benefit from the group.
Yeah, we've also had to tell people who you're driving with. This is a private conversation, so your friends and family can't be around listening in other people's conversation.
I think it's a sign that people are actually so comfortable with virtual technology in this day and age that it's very casual. You know, that's just sort of doesn't have the same sacred feeling of walking into a space.
Any other stories, personal experiences, how everything is going currently with COVID and telehealth?
I can share something about groups, whether it's Ryan Morrison. I've run into a lot of people who come up with really weak excuses to miss group, so that they can, because it's so much easier now to do a makeup group, especially now that we're all sort of being much more forgiving, because we're, oh, well, the technology, you know, we can't, you know, it's understandable you got a technological problem, you can't get on the phone, but it's not it wasn't understandable in the past that you couldn't get travel to the clinic. And so we see a lot of people just trying to avoid the group, just try to make this just a super quick, just hi, bye, send me subs, see you later. And it can be frustrating to try to pressure engagement in that scenario.
I think that alludes to what Laura was talking about last time, where we do have some patients who will try that, but then the following week we'll call them out on it and say, hey, what happened last week? You just stayed for a few minutes. You got to stay for the whole time, for the med management time and for the therapy session. And so that counts as your miss. And this is our rules regarding your misses. And so if you want to stay in the program, this is what's required, is you got to stay for both my session as the prescriber and the therapy session the whole time.
This is Ashley calling from WB.
Something else that we've did too with patients that consistently say they have a bad connection and then end up dropping out halfway through group therapy and things like that. We've actually set up a couple extra offices here at Chestnut Ridge and put webcams on the computers and things like that. So we, if a patient consistently gives excuses and so forth, we ask that patient to start coming into the office and use one of our Zoom rooms.
We got a question also in from David Baltierra asking if anyone knows of a virtual group tip sheet and rules.
Yeah, you guys are actually writing it right now through this, so we could transcribe this, and that's what it would be.
I mean, we have some tip sheets and rules that we use for our clinics that we go over for patients and stuff. So we could send that to you, David.
That would be helpful, because we've just struggled so much to just get them on video and Zoom that's been our first thing, just spending so much time on that I think the next step is this. Just bothers me when everybody's smoking and I'm like, you know, and they can't hear you. And so we've just been taking it one thing at a time. And so this is really the next step, which is going to be really helpful. because there is a certain chaos, but I think that chaos needs to evolve into, more therapeutic, and some have been really good and some have been not so good, the groups, and for lots of reasons, but some of it's just bandwidth and getting people on, and we have done what you guys did, Douglas, which is having them come in. Unfortunately, one of those patients ended up getting tested for COVID, so it just kind of escalates. But so yeah, just to continue to be careful.
Thank you. And Sarah chatted in, do you have a plan to end Zoom visits anytime soon?
We're not ending Zoom visits. We're encouraging more we have a group room, and we're encouraging our clients to come in. One being, we had a client who would make us all sit on the floor, so we found it better for him to come in. Several of the clients have expressed wanting to come back and wanting that group. So we opened up a group room. It is equipped like someone else mentioned, with audio and video, so the instructor can be away, but the clients will still have each other, and we're still offering Zoom, but we don't have any end date. But we're offering like a hybrid normal group.
Thank you for that.
We also plan on continuing our virtual meetings into the foreseeable future. We're slowly bringing back some patients in person over just our general psychiatric services here at Chestnut Ridge, but we definitely plan on continuing to do our virtual visits as our default, even our groups as our default, just because we have the luxury of being able to do that now, unlike a lot of other clinics out there, and see how this proceeds. And in many ways, it's been beneficial because obviously some barriers have removed from transportation requirements, and able to reach people in further distances, et cetera, and the convenience of doing this. So I anticipate us to have this as a huge part of our practice portfolio going forward.
I was thinking as a group, we should probably come up with a list of labs that we can identify for certain patients in certain areas. Hey, go to this lab, get this urine drug screen done. So we can just fax because I think we use the send out the California PAX talks for our clinic. And so it'll be really helpful if you all have labs in your area that you trust and they do a good job. We can have that list, and so we can connect patients with the appropriate lab.
Yeah, we were asking the same questions among ourselves with some of our administrators of how do we go about making sure patients know which labs. And what came back to me from several of the other providers is that most of the patients seem to know where their local labs are. And yeah, it was something that kind of surprised me as well, but I was asking for the same thing as you were, Adina. If we could start putting together a list of where are the labs in various communities, so at least people know this is where you got to go to get your labs, or this would be a good place, instead of having to come all the way out where we are, for instance.
But James, isn't that the problem we've run into is some of our patients, nobody has a printer anymore, so then it's more work. And so I've been sending it to them through my chart, but then I think they're just showing that to the lab, their little phone. So because Epic, you can fax things, but it's not turned on. So there are some technical issues that I think over time we'll need to work out, because you're right. I think the patients can, figure it out, but sometimes it's across state lines, different part of the state. I have somebody in Wheeling that we're treating now, which, she couldn't come down here before because of parole stuff. So there's a lot of advantages, but some of the other things, people are going outside of our system. So it's a little harder to order those. And then as they talked about, some of the quality, I'm just taking what I've got, whatever they do. And so we'll see. We haven't done a lot of that yet, but it'll be interesting to see, what that means,
Yeah, and also we can maybe with that have the policy at those labs to supervise urines, because some will and some won't.
Does anyone else have any questions, comments, experiences that they've
I have a question about video and Zoom and these groups. Is everybody using Zoom, or we've transitioned through the university to video because of some security concerns from our university here? Are people locking that? Are they? What are some best practices? Because we're trying to get some of those, which is, for example, creating a new meeting ID for each group so that they, somebody can't use that later at another time. Also letting people in through either a waiting room or some type of list, but that creates more work for all of us. And so I just want to know if people are doing those kind of things, aren't yet, where people are with that.
So we've been using the same format. I think we got ours from with Jim So's group in Morgantown, and we do have an administrator who actually lets people in a waiting room. And our caseworker Cheryl is going to be the one to go over all of the group rules before groups and so forth. And we've been using Zoom, and we have a secure platform that's HIPAA protected.
Yeah, same with us. We are still using Zoom for our COPE programs. At some point, David, we're going to probably have to move to the Epic group video as well. But right now, that's going to be like phase 3 or 4 for us.
Okay. Yeah, and just to let you know, they're building that through Epic, so it may be worth waiting if you haven't done too, because if not, you're going to have to make 2 transitions. We hadn't done too much, and our local people were more concerned about security, and although the university Zooms fix that, so I know that the IT people are building the groups, and so that I'm not sure we need to do too much until that point.
Yep.
I also got a chat in from Sherry Dale saying that they use video, that's VIDYO, with a new room for each group session.
Zoom is the only thing that really seems to work well with group. That's what we're doing.
We use a platform called DoxyMe, and we haven't tried it with a group, but we have a small group in that I'm in one room and our case manager Amy, who's on the call today, is in another room, and the patient's in another room. So theoretically, we could do a group. The connectivity and the number of people that we have who don't have internet access, I think, is what two of our limiting factors in trying to do a group. It's really, with some people, the connectivity is fairly atrocious, and about a third or maybe half of our people, it's telephonic, the contact.
We have that same problem here, and we just have them telephone in on Zoom. And we'd like to get them all to video. That would be nice. Then I could stop all the smoking. I'm pretty sure I have a patient or two that's actually intentionally avoiding downloading Zoom so that they can stay with audio only and use drugs in the middle of the call. It's pretty frustrating when they come up with all kinds of crazy excuses about why they don't want to download Zoom. But I do think the video version is the best way, because of the way you can keep them accountable. With the audio only, you don't know who's with them, you don't know if they're driving, you don't know if they're doing drugs, and probably all those things are happening.
And then it might be worth thinking through at some point for those people to say, okay, you need to, since it hasn't been working for you, you need to come in and be seen. We'll put a group room together for you. The way we do here in Morgantown is we'll put together the technology. You got to come in here and do the technology at least for 90 days until you're stable, and then we could look at transitioning you home, and hopefully you'll figure out the technology by then.
And that seems to work more often with patients than you would think, because just for an example, last week we had a patient that seemed like every appointment, her phone would break up, or she'd say she didn't have signal, couldn't call in. So we finally got to the point where we required her to start coming in and using one of our extra rooms, which she did. And she only had to do that one time, because remarkably after that, she has a smartphone and she has good cell phone coverage and good Wi-Fi, and she's been on every appointment since. So.
So we have about 10. Oh, sorry. Go for it, Jennifer. Sorry about that.
That's a very helpful suggestion. We've just been really concerned about a number of our patients, and we've increased our contact with people who are having weekly short behavioral health visits, but we've just seen people really struggling, and a lot of people have said, I can't wait to get back in. So even if we did it with them in a different room, maybe just that contact would be
something else too, Jennifer, that you could do, since you have such a high volume of patients that don't have internet access, which they might actually not, especially in a rural area. If you only have like 2 extra rooms that you could turn into Zoom rooms, just alternate the patients each week. And then that way, at least you can lay eyes on, these couple patients one week and a couple other patients the next week, and so forth.
Yeah, great. Thank you.
Douglas, we got to thank you for the accountability comment and how important that is. So we have a little under 10 minutes. Any other comments, questions? I love this conversation. It's great. We can keep going for 10 minutes. Jennifer, I noticed, I remembered you said some of your patients kind of miss coming in person, but I was going to see if anyone, do you see your patients preferring group meetings through Zoom versus in person, or vice versa? Has anyone seen that?
We ran a therapy group today for the first time in person, and the feedback what we got was, man, we're so happy you guys had this option. It was all through Zoom, but a lot of the clients had mentioned they need to be in the facility versus Zoom, because they felt like Zoom, they just couldn't get the privacy they get for coming into an office. So definitely we saw a lot of our clients just wanting to be back to normal.
Anyone else?
I think it's been a mix for us too. It seems like there have been a group of people who are just totally content and satisfied continuing this virtual thing. And then there's another subset that just really miss having the in-person contact and are getting really, really fed up with being isolated.
It has been neat watching their comfort levels increase, though, with group doing it through Zoom. Just when we started this, it was very much surface level discussions in group. But then as groups got more comfortable and people got more comfortable and trusting each other, they were able to take the conversations to much deeper discussions. So that's been nice too.
Well, we have a little bit of time. Let me tell you about one of the possibilities that we're going to start piloting is this oral drug swabs that we can use for drug testing. So instead of having somebody come in and provide urine in a lab, this is an option that we are going to be able to roll out to our hubs and spokes, where the patient gets mailed a test kit that they would then put in their mouth. It's a swab, and be able to be watched in real time by somebody on your team, and then they're able to show you the results on the actual video. So we're going to start asking who needs some of these, and then to start trying that with your patients in the community. We're going to start it, I think, this week, aren't we, Douglas, for us?
Yeah, I think we're going to actually start asking patients tonight if they would rather have them mailed or come in person for urine drug screens.
That's excellent. Thanks for sharing that.
Regarding the drug screening, has anyone heard anything from state regarding exactly how much we absolutely have to do? We're certainly under pressure to not do too much. I'm just curious where the line is, if anybody knows.
I think the state has removed all barriers to treatment, meaning there are no specific requirements. You are free to do what you think is clinically prudent.
Yeah, but that advice is coming from a cat.
Hey, Mary. Well, I'm telling you, the cat's smarter than I am, so no, that's coming from Cindy Bean with Bureau of Medical Services and Medicaid.
Thanks,
Don't
Mary.
you agree, Jim? That's the best looking picture of me you've ever seen?
Yeah, probably.
Unlike Ryan, I'm not at the beach, so hey.
Exactly, he living good.
I wish we could all teleport to the beach. That would be nice, but the background looks great. Any other comments, questions? We have about 4 minutes left. I don't want to hold anyone longer than we have to, but as always, feel free to email me or anything, reach out if you have any questions or anything you want to address. I'll make sure to have those covered. So 2 Mondays from now is Memorial Day, so we will not be having our session then. Our next session is going to be on June 8th, which sounds really far away, but it'll come by really quickly. So we'll send out reminders for that. And yeah, everyone, please stay safe. Enjoy your Memorial Day. I know there's not much we can all do, but try to enjoy it as much as possible. And thank you all again. Thank you, Dr. Barry, for all the comments and questions, and Phil for the excellent didactic. We really appreciate it. We'll see you guys next time.